Very good morning, everyone. Hope you're all ready for a content-packed webinar with us today. Today's session is bittersweet as I host the last session for the most enriching webinar series that span the last few months, helping us up our rehabilitation game ranging from smile design strategies to deprogrammers and selective FMR, and finally to today's topic, the most important but often overlooked concept in dentistry. We thank you all for joining us today for the webinar titled Customizing Occlusion and Troubleshooting When, Why, Where, and How. Our sixth and last session of the clinical series, Harmony Between Function and Aesthetics, organized by Dental Reach. Dental Reach is a professional site and forum for dentists. It's a place to be visible as a dental practitioner and get appreciated by fellow professionals. Thousands of dentists use Dental Reach to find reliable information on dental education, just like you all are here to up your dental game today. I'm Dr. Urvashi and I'll be your host and host for the session while we venture into the last part of smile rehabilitation strategies with none other than Dr. Deepa Ravichandran. Sometimes we need to selectively customize the occlusion for patients. They could have a completely rotated premolar or an opposing crown which has invaded the interocclusal space of the present tooth. So where do you then get the space for forming this one? Let me introduce you all to Dr. Deepa is a prosthodontist in Navi Mumbai, where she runs a successful health dentist. She has won the base her master both has many publications in journals guided you. Presently, she is the brand ambassador and moderator of Dental Reach, the recipient of the BOMA Award for 2021 and 2022, recipient of Doctor's Choice Awards, National and City Winner 2021, mentor for the Pulp10 Activa Pronto Challenge, silver winner in the Dental Divas Endo Resto Contest 2021, contributing author in How to Conquer Dental School, a one-of-a-kind novel giving young undergraduates a unique perspective in navigating the maze that is dental school. Her forte lies in full mouth rehabilitation, smile designing, and restoring cases of complex occlusion conservatively. She has received acknowledgement for the same from peers and patients alike. The stage is yours. Over to you, Dr. Deepa ma'am.
Thank you so much, Dr. Urvashi, for such a wonderful introduction. And I'll get on with the
Dr. Deepa, we can't hear you properly.
You can't hear me? Just give me a second.
Slightly louder. Slightly louder.
Can you hear me now?
Yes. Pretty clear.
Okay. Yeah, just 1 second.
Do you want to switch on your audio? Do you want to switch on your video for the presentation?
No. Without the video itself, it is, how do I put it? 1 minute. I'm just
okay. Can you share your screen?
Yes. Yeah. I'm trying. Just give me a second, please. We have done a dry run of the screen shell, and are you able to see the screen?
Yeah, I can see the screen. Not the PPT yet, though.
You cannot see the PPT?
No, we cannot see the PPT. We can see your screen where all the documents are there.
Okay, no. Hold on 1 second. I don't know what happened. Okay, it's something happened. Just give me a second.
So guys, meanwhile, if you do have any doubts regarding occlusion or this particular topic that we are hosting today, feel free to jot down any queries that you may have in the Q&A box, and we will answer them by the end.
Yes. So I think my presentation is visible.
Yes, we can see your presentation now. If you could just go on slideshow mode.
I'm already on slideshow mode. I'm on full screen mode. It's not visible?
No, we cannot see the full screen.
But I am on full screen.
Okay, can you change the slides? Let's see if that.
Is this visible?
No, not yet, ma'am. We can only see your PPT, but we cannot see it in full screen slideshow mode.
Is this visible now?
Yeah, we can see that the slide has advanced to the second slide,
Okay.
but it is still not in full
Good.
screen.
So we just do
It,
that. This was done in the last session also. I think that's okay.
okay, sure.
Just go
No
ahead.
issues. Go ahead, ma'am.
Yeah.
Yeah, yeah.
So our topic for today is customizing occlusion and troubleshooting occlusion. So when can you do it? Why do you do it? Where do you do it? And how do you do it? These are very important questions. So in this webinar, I'm not going to be speaking on complex theories of occlusion. Rather, I'm going to be discussing certain specific cases chair side where I had done something different because that particular case demanded it. A little tweak for aesthetics or a little tweak for function. So I have three cases in this webinar, and each of these cases are very, very different. So this is my first case, and you can see that this is a case of a rotated premolar, and it's not just one premolar that's rotated. It's rotated by 90 degrees. So we have both 2.4 and 2.5, which is posterior to 2.4. Both have been rotated 90 degrees. There is this um, pocket over here along with recession, and you can see a restoration over here, which was a very deep class 5 due to aggressive brushing. So now the reason why this class 5 developed in the first place was because this is actually the proximal surface of the tooth. And the contour of the proximal surface is not such that it can withstand brushing. So when the tooth is rotated in the oral cavity and it's the proximal surface which ends up being placed buccal, it gets abraded very, very easily. And that's exactly what happened in this particular patient. So given the fact that this tooth was rotated, I wanted to customize the aesthetics for this particular patient because it looks really, really weird when you see the patient from the front. And post root canal, we were just discussing me and the lab as to what was the best solution that we could give this patient, and we didn't consider overlays for two reasons. Because overlays are conservative, yes, and they do preserve the tooth structure, but then they cover a limited amount of tooth structure, so I cannot do drastic changes in shape. And the second thing is, many root canal treated teeth do discolor below the overlay, and there are patients who don't like that. So this is another reason why are very often crown teeth once they have undergone endodontic treatment. This is the cast, and this was the test drive. Now, what do I mean by test drive? What I mean is we decided to try this particular shape. Okay, so we have the 2.4 here and we have the 2.5 over here. Now, both 2.4 and 2.5 are rotated 90 degrees, and 2.5 is posterior to 2.4. So we decided to give this type of a shape whereby it looks like a molar from the buccal. It looks like a molar from the frontal when we look at the patient, but the occlusal is according to the original shape of the tooth. Now, one of the questions that even the patient asked me in this case was, why not just extract this tooth, which is 2.5? Okay. The reason why we could not extract 2.5 in this case was because it was 2.5 that was in occlusion with the opposing premolar, not 2.4. So it was 2.5 that was in centric occlusion in position of maximum intercuspation with the opposing premolar. It was 2.5 that was also, in occlusion, disoccluding in excursion. So since, 2.5 is the one in occlusion, it's not so simple to extract it. And we cannot extract 2.4 because then we're going to have a huge buccal deficit over here, which is going to become very, very difficult to fill up. So this was the reason why neither of the two teeth could be extracted. Now, regarding orthodontic treatment, yes, that is ideal. But the patient was an investment banker. He had long hours, and at this stage and this point and this time in his life, he was not interested in orthodontic treatment just for a single tooth. So, from the patient's perspective, we had undergone endodontic treatment for one premolar, and he simply wanted some aesthetic solution in the form of some type of cap, in the patient's words, and he just wanted the story to end there. So, in such cases, when we are trying to customize shape in aesthetics, we have to go in for a cat-can crown, because you can see very clearly over here that the margins are, very, very fine, and there is a fine line between having a crown with a good seal between the 2.4 and the 2.5 and having an open margin. So what you see over here, the slight open margin that you see here, that is because this was a temp. As I said, this is a test drive. So we needed to be able to remove the crown and put it back several times on the cast during fabrication. And, a slight, space was left in order to be able to achieve this, because we were not sure if the patient is going to adapt to it, if it's going to fit on the tooth, if the patient is going to look fine, if the occlusion is going to be fine. There were many factors. So anyway, so this is what it looks like from the buccal. The patient adapted so well that we just went ahead and we fabricated the same crown in the same shape in the final. So the final is in zirconia. This is the final. Now you can see that the shade of this final crown over here is not an exact match to the canine over here or to the molar over here. And the reason is because the test drive crown was in a typical shade of A1. And the patient liked it so much that he decided that he wanted the final to be in the same shade. So despite me trying to convince him and trying to say that, that was just the test drive shade and we don't usually have too many shades available for a temporary crown, but that's not the same with the final, he was adamant that he just wanted to go ahead with the same shade. And so I gave him the crown in the same shade. And you can see that this is the final occlusion. This is the occlusion on the patient's right, and this is the occlusion on the patient's left. And aesthetically, I think this has done a wonderful job of masking the fact that both the premolars were rotated, because it simply looks like this is now the first molar and this is the second molar and this is the third molar. So it's not very, very visible, So this is a very good aesthetic solution and a functional solution for patients who have rotated premolars, because very often we get cases where the premolars are rotated and patients are not interested in undergoing orthodontic treatment. Now this is my second case. Okay, so this case is a little difficult. All the cases are single crowns, but each case had something special. Each case had a particular challenge that was specific to that particular case. So in this particular case, the patient came to me and he underwent endodontic treatment in 2.6. Okay, and this is the image which was taken after the crown prep. Now you can see that the interocclusal distance between 2.6 and the opposing 3.6 is actually very, very less. Okay. Now the reason for this is because 3.6 is not actually a crown. This is an overlay, and it was endodontically treated, and the tooth below that has completely discolored. So this is what I spoke about earlier when I said that when we give overlays to teeth that are endodontically treated, they sometimes discolor below the overlay and the patient doesn't like it. So, this was one of the things that this patient also pointed out to me. And he said that, even after spending so much for a zirconia partial, my tooth is still discolored, and, I don't want that in my upper. So I want a proper cap this time, and I do not want to go in for an overlay. Now, it didn't really matter whether he wanted an overlay or whether he wanted a crown. The fact was that the interocclusal space was very, very less. The reason for that is because the dentist who had cemented this particular overlay had reduced the upper tooth because there were high points. Okay, the patient is basically merchant navy. So when 3.6 was cemented with the overlay, he basically had acute pulpitis. He underwent endodontic treatment at Port, and he was there at Port for only 2 days. So the clinic and the lab were very, very stressed to not only finish the endodontic treatment for the patient, but to also give him some indirect, which was the overlay in this case. So the patient's bite is tough. As you can see, it is an edge-to-edge bite over here, and he has a complete reverse curve of SPE over here. He has an occlusal cant over here. So this is a very, very tough bite to fabricate an indirect for. And typically these kind of cases cannot actually be done in a rush job in just a day or in two, because even if you do make the impression and take a bite, such patients sometimes exhibit a mild shift in the horizontal plane at the time of making the wax bite. So even a slight shift in the horizontal plane, even if it's only zero point 0.1 or zero point 0.2 millimeters, would drastically affect the occlusion and the seating of the ovary, which is exactly what happened in this case. So pressed for time, the clinician had simply reduced the opposing tooth in order to get the bite to close and had cemented the ovary. So that solution worked at that point for that clinician and for that tooth. But now when we come to this tooth, we do not have the space to crown this tooth. We do not have this, and the tooth has very less vertical height. Okay. So when the tooth has such less vertical height, I cannot give an overlay for this case, even if I want to. It's not possible. Okay. Because the vertical height is so less. So why didn't I consider a bonded restoration like lithium disilicate? Simply because of the patient's bite. The patient's bite is so terrible that I did not want to go in for lithium disilicate in this case. So the case would have to be done either with zirconia or with, all metal or with a PFM. It is not possible to use lithium disilicate in such cases because there is a very real risk of fracture. Okay, since lithium disilicate's compressive strength and its fracture resistance cannot be compared with that of zirconia. So if I have a patient with a bite like this, I do not prefer to give lithium disilicate. So now this left me in a conundrum. I could not reduce the tooth height beyond this. Now, for all those who are wondering, why didn't I consider crown lengthening? I don't usually consider crown lengthening for patients where I have a problem of reduced interocclusal space. I try to manage it prosthetically because there are two reasons for that. Now, crown lengthening is a separate procedure in our practice for which we need to charge the patient separately. So that does become an added or an additional cost to the patient. That is the first thing. The second thing is that these type of cases are not simple CLP procedures where we only remove a little bit of the gingiva and we are going to gain more tooth structure, thereby allowing me to reduce a bit more occlusally. It's not that simple. Most of these cases end up being cases of osseous reduction. So I am never very, very keen to do osseous reduction in patients because, uh, you know, for me to be able to gain about, I would have to reduce the occlusal. For me to be able to give a crown with a decent interocclusal space, I would need to reduce at least another 1 to 1.5 mm of the occlusal space, which means that I would need to increase the length of the tooth by 2 mm. So if I have to increase the length of the tooth by 2 mm, if you do the math, you know that the bone, the distance between the bone and the distance between the junctional epithelium is 2 mm, and that is known as the biological width. So if I have to maintain the biological width of 2 mm and gain 2 mm in axial wall height, I would effectively have to reduce 4 mm. So that just becomes too much. So that is the reason I do not consider CLP in such cases, and I try to instead manage the case prosthetically. So how did I do it? Once again, a complete digital workflow is very, very important in such cases. So this is the exocat of the patient. And as I said, these kind of patients have a tendency to have a slight or a mild shift in the horizontal plane. The reason they are able to exhibit that shift is because they have a very less vertical dimension in the posteriors. And the less vertical dimension allows them to exhibit that shift in the horizontal plane in 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 a side to side direction. So a bite alone is not sufficient. One needs to provide the lab with photographs, good quality photographs in all three planes. Now, ideally, if you have an intraoral scanner, that is the best for such cases. You avoid a lot of drama, both with the lab and chairside. But if you do not have an intraoral scanner, this is the next best way to do the case. Now, the patient didn't want to spend for zirconia at this point for this particular tooth. The reason is because I now there is a lot of patient management also involved with such cases chairside. Yeah, I cannot promise the patient that I would find a solution without touching the opposing tooth. I can only tell the patient that I will try, which is correct in all honesty, because it's never wise to promise patients anything. I told the patient that I could try to not touch the opposing overlay and I would try my best because obviously being a zirconia overlay, it was expensive. And yes, there was a warranty attached, but then he got it done at port. So it's not so easy for him to go back to the same clinic at the same port and claim his warranty back if the opposing were to fracture in case I adjusted it, chair side. Because keep in mind that there was already a history of the clinician having already adjusted both the opposing tooth and that overlay in order to get the bite to close. So I have no idea what the thickness of that overlay was initially, how much the clinician had reduced chair side, and what was the final thickness of the overlay at the time of cementation. I have no idea. So there could be one area which was really, really thin, and if my burr touched that particular area, it could just fracture. You never know. And if that happened, he would have to change that overlay along with paying for a crown for this tooth. So when the patient thought about, that kind of finances, it was giving him a little bit of anxiety, considering the fact that this overlay had been cemented just 3 months earlier. So that was one of the reasons why he did not want to pay for a zirconia crown for the upper. Now, for the reason of aesthetics, we went in for a PFM because an all metal crown is not only very heavy, but it really looks really, really bad. And in today's in today's time and in today's age, there are very, very, very few patients who willingly go in for all metal crowns. Most of the patients in my practice, in fact, go in for metal-free crowns, and then there are these odd patients where we end up choosing PFMs for certain reasons, such as this. So this was what the lab sent me. After the fabrication of the PFM crown over here, the lab marked this particular point and he said, look, there is a high point which is coming on the distal lingual surface of the opposing tooth. So you would need to do a little bit of enameloplasty over there. Because on a die, it is very, very difficult to make out whether it's an overlay or whether it's the tooth itself. So now I really did not want to touch the opposing overlay and take up responsibility if anything untoward happened towards it, because these are never good ideas with patients in our practice. So I tried to do the next best thing in this case, which was this. I told the lab, I do not want to touch the opposing. Instead, remove the ceramic completely from the area of the crown that we are fabricating on 2/6, where there is a high point. And we leave the rest of it in ceramic, and we just leave this one area in metal. And this area was highly polished before it was cemented in the patient's mouth. This was the only solution, and this was the best solution that fit in all the parameters and criteria for this particular case. And this is something I discussed with the patient before I did it, of course. And the patient was very happy. He had no problem with this little bit of metal being exposed because everything else fit in. The opposing tooth, the overlay on the opposing tooth didn't have to be touched. It was within his budget. His warranty for the opposing overlay would not need to be claimed. His work was getting done for his 2/6 without touching the opposing tooth. And this is not going to be visible. Since this comes on the occlusal surface, it's not going to be visible to anybody except us when we use a mouth mirror. So it really didn't matter to the patient. So it was a win-win for everyone. And we went ahead with this solution. And this is the crown in final occlusion. Okay. Despite despite leaving the occlusal surface in metal on 2/6, okay, it was still not enough. It was still marginally high by about 0.2 millimeters. And that is the reason you see the slight bit of the bite having opened up on the canine over here, very slightly over here, okay, these two teeth over here. So when we talk about 0.2 mm, that's actually 20 microns. And I told the technician, it's fine, just go ahead. Because up to 20 to 25 microns, the temporomandibular joint and the musculature will adapt without any problem. The patient does not feel any pain. The patient does not feel any fatigue in the musculature. Adaptation takes place up to 25 microns max. So 20 micron increase in the BD, very, very slightly, is not going to make much difference to the patient. It's negligible. The patient is going to barely perceive it, which is exactly what happened. So this is the final occlusion of the patient. And you can see that the occlusion on the right of the patient has not opened up, even though here we have opened up the bite by 20 microns, okay? And even though the patient has a reverse curve of SPE over here, the patient had a reverse curve of SPE in this arch too in the beginning, but he doesn't have it right now. I'm going to go back to that very first slide so that you would appreciate what I'm talking about. You can see over here, you have the canine, then you have the premolar, then you have the premolar. So basically, it comes like this, and then the arch goes up like this. So it's kind of like this and then like this. So this is a reverse curve of SPE over here. But when I finally gave the crown in occlusion to the patient by raising the VD over here by 20 microns and doing a little bit of enameloplasty in the canine over here, I managed to achieve a proper plane of occlusion over here without this side going in a reverse plane of occlusion. So considering how much we are able to achieve with just these tiny little modifications, it is really well worth it. So this is what I meant when I said we customize the occlusion chair side for that particular case and for that particular patient. Are there any questions with respect to these two cases? Dr. Urvashi, are there any questions? Does anyone have any questions? Dr. Urvashi? Hello? Dr. Urvashi? Am I audible?
No questions. You are audible.
Okay, fine. So I'm moving on to the last case of this presentation. This is another tough case. Okay, this is case 3. This patient came to me and she complained of repeated fracture of the crown on 3/6. And it always fractured in the same position. It always fractured on the distal marginal ridge. It had fractured twice, and both the times it was a PFM. And she came to me because she wanted a permanent solution to her issue. Now, as you can see over here, once again, this is a case of very, very less vertical dimension. The vertical dimension on the right is a little bit better, but the vertical dimension on the left is far less, okay? And again, you can see that there is a kind of a reverse curve of SPE over here. And the interocclusal space is again very less, okay? So I cannot reduce, but again, it's the same conundrum again. I cannot reduce the occlusal height of this tooth anymore in order to gain more interocclusal space, because if I were to do that, the height of the axial wall would become too less and the tooth would become completely non-retentive for a crown, and then the crown is going to get easily displaced because there is something called arc of displacement. So if we do not maintain a certain axial wall height, the crown would not be able to resist that arc of displacement. And as I had mentioned, the reason for not doing a CLP in this case in order to gain that extra height in the axial wall remains the same. So, as I said, I try to manage these cases prosthetically rather than doing any type of osseous resection for such patients. Now, before we go ahead and before we fabricate a new crown for the patient, we really need to understand why is the fracture taking place, because there is always a why, okay? Especially if there is a particular pattern to the fracture. If the fracture is going to constantly take place on the distal marginal ridge, it means that there is definitely an issue with the bite where the opposing tooth is concerned in this specific area, okay? So we need to understand what the issue with the bite is. Unless we understand that, we cannot prevent the fracture from taking place a third time with the new crown. So such cases need only a CAD/CAM crown and they require a complete digital workflow. It is not possible to fabricate crowns for these patients in the old-fashioned manner, which is PFMs, based on the lost wax technique. So when on asking the patient was not really aware of CAD/CAM technology or CAD/CAM crowns, and I definitely do not think that PFM was CAD/CAM based, and I'm very sure that it was made by the old-fashioned lost wax technology. And when you do not have crowns fabricated with the CAD/CAM technology, these type of fractures in cases where there are bite issues are pretty common. So now when you analyze the case in ExoCAD, you can clearly see that the opposing 1/6 is completely tilted. distally. Okay. Now, enameloplasty on the distal aspect of the opposing 2/6 was out of question because the patient told me that certain adjustments had already been done by the previous clinician at the time of cementation. So that does not leave me with much scope of doing any further enameloplasty over there. So touching the opposing 2/6 was now out of question for me. Otherwise the patient was going to end up with severe sensitivity, and then I would have had to do some type of indirect over there too. And I try to avoid these type of unnecessary treatments for patients in general. Now, the VD is very less. Even if I want to give the patient monolithic zirconia, it's still less even for monolithic zirconia, not everywhere, not all over. See, typically in these type of cases, you have very less VD, but it would happen in a very, very specific place. So in this particular case, that happened on the distal marginal ridge only of 3/6, where the interocclusal clearance was too less for even monolithic zirconia, but it was fine everywhere else. So I had to come up with some other solution for this patient's problem. So I did the same thing what I did in the previous case, which was raise the BD by 0.2 mm or 20 microns, which is very, very negligible. And that led to a very, 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 very slight opening of the bite here and here, but it's almost negligible. But in this case, it worked out. Why? Because a patient already had, a lack of complete intercuspation on the right side. I can go back and I can show the pre-op. And when you see the pre-op, this is what the right side looked like. You can see that the patient lacked tight intercuspation on the right, but the patient had very tight intercuspation on the left. So that again means that there is a lack of balance in chewing and in the excursive pattern. If the occlusion is tight on one side and not so tight on the other, it means that it's more closed on one side and it's not so closed on the other. What does this translate for the patient? What does this mean practically? This means that the tighter the intercuspation on one side, the more the patient is going to favor that particular side on chewing and in mastication. So therefore, there is going to be a higher risk for any type of restorations or any type of indirects that we have given the patient on that particular side. There is going to be a higher risk of fracture simply because the patient tends to favor only one side on chewing and the chewing forces more, and then there is a lack of balance. That's very, very important. There has to be balance in the excursive movements and in the chewing patterns on both sides, especially in cases like this where we have very, very less VD posteriorly and where the patient comes complaining of repeated fractures. So by raising the bite over here by 20 microns, I have effectively tried to give the patient the same kind of lack of tight intercuspation over here on the premolar as the patient has over here. This is to give the patient the balance that she didn't have previously. Now, this requires a very, very skilled technician to process such cases. A technician has to be a little experienced, has to understand what I'm talking about, has to understand the importance of 20 microns. Okay, so these are generally technicians who have some knowledge of occlusion, and they've worked on complicated cases, and they understand that up to 20 or 25 microns, that is the max that you can fiddle around with the occlusion and with the bite, and you cannot fiddle and fidget beyond that. So most patients adapt very easily. Up to 20 to 25 microns, as I said, it is negligible. The patient doesn't feel anything. To the patient, it's nothing. The patient does not even know that you've done it. Okay, it's as simple as that. And this is the excursive movements of this particular patient. So keep one thing in mind: whenever the vertical dimension is less in the posteriors, the patient is always going to exhibit some type of group function in excursion. So if you see over here, the patient doesn't just have posterior group function, the patient also has something known as anterior group function, where the lateral incisors and the canines are also touching. And similarly over here. So when you are giving the patient a single crown, it is not possible to drastically change the occlusion and give the, completely convert the patient from group function to canine guided. It's not possible. So the best thing to do to avoid fracture of the crown and to avoid further damage to any of the other teeth is to just follow the pre-existing occlusal scheme, and the same thing was followed here too. So we just went ahead with group function in excursion, but the point is I tried to give a balance. So if we have the canine and the lateral in anterior group function here, we have the canine and the lateral and anterior group function here too. And if we have the premolars and the molar over here, I've tried to give the premolar and the molar here too. Here, of course, this here, we have one extra tooth, but that's okay because in group function you need minimum 3 contacts, and ideally is 4, but three is good enough. So we've got 3 here and we've got 4 here, and that's fine. So as I said, patients adjust and adapt very, very easily to these minor little tweaks where occlusion is concerned. But yes, you really do need to understand the case and understand what you can do where and what are the limitations, because the limitation is 20 microns. You cannot go beyond that. So whatever you're able to correct within 20 microns, that's the max. One cannot go beyond that when you're fidgeting and fiddling around with occlusion. And with that, I conclude my presentation for today. This is one of the shortest presentations of this webinar series, and that's because I wanted to focus only on troubleshooting since the complex aspects of occlusion have already been taken up in the last 5 webinars. Okay, and sometimes it's not the big things, sometimes it's small things that really matter, just right. It's these little things that really drive us crazy and get us really frustrated, because it's, even though it has to move around, and it's not so simple and it's not so easy. And with this, I conclude my presentation today. I hope everybody enjoyed the presentation, and I wonder if there are any questions that anybody would like to ask me.
Dr. Deepa, if you could please switch on your video. Am I audible to you?
Yes, you're audible to me, and I have switched on my video doc. Am I not visible?
Not yet, but can I ask you a question in the meanwhile, if you can hear me?
Yeah. Dr. Roxanne, can you see me?
All good, ma'am. I think some network issue from Dr.
Okay, so Dr. Roxanne is able to see me.
All good,
Okay,
doctor. Can continue.
Okay, go ahead.
Okay, Dr. Deepa, there's a question for you.
Yeah.
Where they've asked how to raise a minor vertical dimension from 0.2 to 0.5 mm.
I would not recommend 0.5 because, as I said, see, when we tweak the occlusion in such cases selectively only for a single crown, only on one side, it cannot exceed 0.2 mm. The reason for that is because the joint cannot adapt beyond 20 to 25 microns. That is your max. Okay, this is very clearly given by Schellenberg. So 0.5 is out of the question. That is just too much. That the patient is going to come back and say, I cannot eat from this side at all. So 0.5 cannot be done. The max is 0.2 to 0.25, which is 20 to 25 microns. Now there are 2 ways to do this. It can be done on the exocad itself when you're milling the crown. See, if it's a monolithic crown, like the last case was a monolithic zirconia. So there is no layering on the occlusal surface. And whatever shade we achieved was through the ingot, the base shade of the ingot itself, the zirconia ingot. And the second is through staining, because that's how you're going to achieve the buccal aesthetics on monolithic zirconia. So when you're milling the crown itself, those very, very minor things can be done on the exocad itself, where when they design the crown itself, they designed it such that they're opening up the bite on the adjacent canine and on the premolar by only 0.2 mm. And it's possible to measure this on the exocad. It is very much possible to measure this on the exocad. So if it's a completely CAD-CAM crown, monolithic zirconia with no layering, this is how it is done. Now, regarding the CAD-CAM PFM, now as I mentioned in my earlier, that was case number 2 that I'm talking about now, the case with the mild tetracycline states. So now again, you do have CAD-CAM PFMs also, but not many people are aware of it. DMNS is not the only form of, digitally manufactured TFMs. You have something called a CAD-CAM TFM also. And CAD-CAM TFMs, you're going to mill only the metal and you're going to layer in ceramic. So here it cannot be done digitally because there is a layering that is taking place on the occlusal surface. This is why a very skilled technician is needed, because this technician has to now sit with a vernier caliper when he's layering, when the ceramist is layering, has to sit actually with the vernier caliper and measure. So how is the ceramic layered? It's actually, you add it layer by layer. It's like how we add composite, when we are restoring a posterior teeth and we want to build up the cusp. It's not all done in one, in one go. If you want to shape it, you want to give the marginal ridges, you want to give the grooves, you have to do it layer by layer. So that's how ceramization is done too. It is done layer by layer. So the initial part, the ceramist doesn't have to worry. It is only when the bite starts to close and when the ceramist is reaching the end that he needs to sit with a vernier caliper and measure by how much, the bite is opening up on the adjacent canine and the premolar, and that it cannot exceed 20 microns or 0.2 mm. So if it's going to exceed 20 microns or 0.2 mm, he has to shave off the ceramic. So it is difficult, and you do need a skilled technician in order to achieve this. You're not audible, Dr. Urvashi, you're not audible.
Okay, can you hear me now?
Yeah.
Yeah, so I hope that answers the question of the participant. I have another question for you, Dr. Deepa.
Yeah.
It is a clinical scenario of a case. So how would you treat a case where there is a rotated premolar, where already there was a crown given, which has been causing some issues with food lodgement, and you have to replace the crown now. So now the crown was given in a derotated manner, but the original premolar was rotated. So now when you're going to give this new crown, are you going to place it in a rotated manner, or are you going to derotate the tooth? And if yes, then how?
See, the issue with rotated premolars is, the buccolingual width of the rotated premolar occupies is more than what a non-rotated premolar occupies. Okay? So basically, the buccolingual width ends up being that of a molar. So now what happens is when you try to give a crown like a normal premolar, okay, now see, in my case, I had the 2.5 just posterior to it. So that was out of the question. I couldn't do that. Okay. Now let us assume that 2.5 is normal. 2.5 is exactly where it's supposed to be, and it is fine. So you have, or let's say that 2.4 is normal and it's 2.5 that's rotated. Okay. So if that is the case, and I try to give a crown, in a derotated manner, I would still have to close the proximal contacts, adjacent to, the distally on the molar and, mesially on the premolar. The reason why this food lodgement is taking place is because when this crown was fabricated, the proximal contacts were not closed. Why was that not closed? Simple. Because if they closed it, that premolar is going to look very, very big. It's going to look very weird in the mouth. See, because as I explained, the buccolingual width that the rotated premolar has occupied is much more than that of a normal premolar. So in effect, the buccolingual width or the buccolingual space that the rotated premolar occupied is 1.5 times that of a normal premolar. So if you try to give a crown with the thickness or with the buccolingual width or the mesodistal width of a normal premolar, you're going to have a gap on both sides, which is not self-cleansing. So if you have enough space that it is self-cleansing and the patient agrees to use a intraoral microbrush or to use a water flosser, then that's different. But very often these gaps are very minor. They are like 0.5 mm, 0.3 mm, and it's not even an even gap. It's more, buccally, it's a little less lingually. So naturally there is going to be a lot of food entrapment because there ends up being an undercut in that area. And that's going to lead to decay of both the adjacent teeth. So the best way to restore such a tooth is cut out the original crown and analyze the space that you have. Go in for a complete CAD-CAM workflow. The advantage with the CAD-CAM workflow is you can see the shape of the tooth on the exocad itself. You can then use the exocad to print a CAD-CAM temporary known as a PMMA. And with that PMMA, you can check the fit, you can check the bite, you can check the aesthetics, you can check the patient's adaptation. But you have to make sure that the proximal margins are correct. So if when you try to do that, it's going to take the shape of a molar only. That's exactly what is going to happen. It's going to end up becoming a molar. Now, this will work fine if, as I said, it was 2-4 was normal and it was 2-5 that was rotated. But if it's the other way around, it is 2-4 that's normal and it's it's 2-4 that's rotated and it's 2-5 that's normal. Now we come into conundrum because you can't have a molar before a premolar. When you look at the patient from the frontal or from the sagittal, because aesthetically that doesn't make sense. You cannot have a crown shaped like a molar before a tooth which is a premolar, because molars have to come posterior to premolars. Premolars don't come posterior to molars. So in that case, now this becomes a little difficult. So now you need to talk to the patient. You may have to involve the premolar also, reshape that adjacent normal premolar also, maybe redistribute the space between both the premolars so that you can give 2 crowns on both premolars, and thereby that little extra space is divided in both the premolars. So instead of one premolar being very, very wide, you redistribute that space between 2 premolars. So you have 2 premolars which are slightly wide. That might be a bit more acceptable in that case. I hope that answers the question.
Yes, it does, more than it does. It was quite a good explanation, ma'am. And I don't think there are any more questions that I can see in the chat box. Occlusion is a really tough topic and often misunderstood and overlooked by many. So your insight into occlusion is really great. Combining that with your clinical expertise and experience really added value to today's session. So thank you for helping us understand and plan rehabilitation strategies in such a simple manner. So thank you so much for that session, ma'am.
It's been
And for all those,
it's been a wonderful journey for me too. I can't believe that this is the last webinar. Time really flies. I mean, we started in September and it's now April, so it's been more than 6 months.
yeah,
And time has just flown. And we've gone through so many concepts of complex occlusion, in the last 5 webinars, whether it was FMR or precision attachment or 2 webinars on anterior guidance. I can't, it's been a wonderful journey for me too, to go into so many complexities, and that's one of the reasons I kept this session really, really simple, because you can't have every session that's really complex. There's got to be something that's a little easier also, and also sometimes it's the easy things that are more difficult. That's also there. The case may not be very complex, but it can still leave the clinician very, very frustrated. So sometimes the simplest things are also the toughest. And Dr. Rajesh, you've been a fantastic host in those for this for the entire DR clinical.
thank you so much.
I could not have asked for anyone else or anyone better. And my heartfelt thanks, gratitude, and appreciation to the entire team of Dental Reach, Dr. Watson, Dr. Zainab, Dr. Nupur, for giving me such a fantastic opportunity, and I've really thoroughly enjoyed myself.
We're glad to have you, ma'am. So for the participants that missed the session, there will be a recording available in case they want to go back and recap on the things that were taught in today's webinar. So there will be a recording available that will be valid for a week. So you can catch up anytime. And with the closing of another amazing session, I would also like to thank our sponsor, Group Pharmaceuticals, for helping us conduct this webinar. And we hope to keep coming back with more such exciting content for you all in clinical dentistry constantly. So thank you, and I'm going to close this session.
Yeah, and for all those who want to get in touch with me, my Facebook profile, my Instagram page, my Facebook page, the links are provided on the last slide of my PowerPoint. So it's Instagram and Facebook is Dental Oxyboards, and my Facebook profile is. Please feel free to get in touch with me if you have any questions on any of the sessions, on any of the cases, on occlusion. I'll be more than happy to help you out in any way.
Yeah, even I would like to take this time to thank Dr. Deepa and Dr. Urvashi for sharing their time with us and teaching dentists for this Smile Harmony clinical series. And Dr. Deepa has mentored almost more than 1,000 dentists during the sessions. Uh, so yeah, congratulations to both of you.
Thank you.
Thank you so much, Dr.
It
Roxy.
was a lovely time. Yeah.
It was. It was.
Thank you. Thank you.
All right.
Bye, everyone.